So here at BC Children's Hospital, I think we probably have one of the newest complex care programs in Canada. Just a bit of historical context. So the hospital created a nurse practitioner position about 8 years ago to practice in kind of an isolated way in caring for these patients, which is clearly not the right model. Alyssa is thankfully still with us, although she kind of went in and out of complex care over the last 8 years and finally gave it up altogether about 3 or 4 years ago, just due to lack of supports and lack of resources. So when I got into my position, it was about 1.5 years ago, and together we've really focused on revamping and re-energizing the program. So I'm really going to focus on the activities that we've been doing over the last about 1 year. It's probably also helpful to know a little bit of context. I think we probably both over and underestimate our similarities across the country. Here at BC Children's, we had a few challenges getting started with our program. This probably looks similar at many of your institutions. There were a number of groups and teams of people looking after patients with complexity who fell into different categories. And probably the most robust program at our hospital was the program dealing with children with tracheostomies and home ventilation. That program has been in place for about 20-25 years, and it runs completely out of the pediatric ICU here. I don't know what everyone else's situation is, but our trach and vented patients are cared for exclusively in the PICU. The other teams, many of which will be familiar to all of you, but the neuromuscular clinic took care of all the children with muscular dystrophy. Spina bifida clinic had some complex patients as well. And then the complex nutrition team started up probably about 4 or 5 years ago, I would say, and they deal with all the children who have home TPN and complex nutritional needs. And of course, like probably many of you have discovered, many of these patients end up being cared for by a subspecialty service, even though they're very multi-system, sometimes with the assistance of nurse practitioners or clinical associates. So we kind of came into this as the field that as it currently was. And what had kind of become clear was that there were many patients who fell into the gaps in between these programs. And when we started, really those are the patients that we really wanted to target, and it seems that there were just more and more of them. Another contextual factor that had a lot of influence on how our program developed was that we don't actually have a pediatric hospitalist program in BC. So our wards are covered by community pediatricians who do sort of 2 to 7 weeks a year on the wards, but have a very busy community practice as well. So we didn't have a very solid pediatric presence at the hospital in terms of a general pediatric service. And I'll kind of go into a little more detail about how that influenced us in developing our program so far. So when we started out, what kind of the powers that be wanted us to accomplish was just to fill the gaps. And to try to find and select and serve these patients who weren't falling into any programs, and thus were definitely falling through the cracks in the system. We kind of fleshed that out a little bit clearly to come up with the following objectives for what we hoped our program could accomplish. And again, this was about 1 year ago. Because of the lack of a hospitalist program here, we definitely had a very inpatient-based slant. Because of the structure of our program, there wasn't a lot of expertise in the care of complex kids from an inpatient perspective. And overall, there was also a big deficit in terms of continuity for these patients. They tended to change attending services every kind of 1 to 2 weeks. So we really wanted to focus on creating some continuity of care for the complex inpatients, many of whom, like I'm sure is the same at your institutions, could be in hospital for 4 weeks or months for various reasons. We wanted to assist with some of the transition and discharge planning process, which I'm sure everybody acknowledges as a very high-risk time. And then from more of an outpatient point of view, we were hoping to provide a single point of entry for complex patients. And I guess that could also be reframed as doing a bit of case management. And we also wanted to develop more of a coordinated plan of care that would cross the spectrums of both tertiary and community groups and locations. When we tried to determine who our population of interest was, I'm going to divide it into 2 phases. The first phase really we developed so that we could get going and get seeing patients and start learning a bit more about who was in this group. So we used really the criteria that was developed by John Gordon in Wisconsin and just adapted it a little bit to try to, we were trying to do a few things. We were trying to capture the right patients, and we were trying not to get absolutely swamped overnight with the numbers of patients. So we came up with these as our inclusion criteria to start with. So the children all were followed by 4 or more subspecialists and had at least a chronic disease at least involving 2 or more organ systems. We had some more specific utilization criteria in terms of number and length of hospital admissions, number of outpatient visits, and types of technology dependence. I won't go into those details, but I'm happy to share that as well. We also came up with a couple of exclusion criteria. If the children were followed by an alternative clinic, something like the Home Trach Invent program, we did not want to duplicate services, so we were trying to be quite careful about not sharing care with those sorts of groups. And we also tried to limit it to children who were less than 16 years of age. We discovered as we went along last year that there appeared to be numerous exceptions to these exclusion criteria that actually may benefit from a different program. I think some patients who are followed in organ-specific clinics or in diagnosis-specific clinics also had some need, although probably not as great as the children who clearly did not fall within those. And the other thing that became clear was that these children in the kind of mid to late adolescent groups were a very difficult group in terms of planning their transition. So we have made some exceptions to these transition ages in terms of trying to assist with that population as well. The reason we originally excluded them is just because we felt it was something that was too big to tackle when we were in a very, very kind of small team. We are also, at the same time, planning phase 2 in terms of figuring out who our population is. And we're doing this actually as a research study. I'm working with a group here to develop an institution-specific definition of complexity. Now this would be, I guess, a tailoring of a definition like A.L. Cohen's and the more accepted definitions of complexity. We feel that there's value to this because every institution probably has a slightly different complex of services and geographical factors and patient populations that makes each program's sort of target population a little bit different. And we wanted to ensure that both that the appropriate patients are targeted and that patients who clearly have enough services are not. And we also wanted to use this type of methodology to better identify the gaps in care that exist, and hopefully with that extension to finding better ways to fill those gaps. So the methods that, just in case anyone is interested, we're using a mixed method methodology, including chart reviews of complex patients and interviews with expert clinicians to form a conceptual model, which we will then hopefully transform into something that actually could be applied to a specific population. One of the most interesting prominent features that has come out of this work so far is just the idea of social complexity and how does that play into our complex care programs. So if anyone wants to talk about that more, please let me know. Our current patient population, I just wanted to give you an idea of the geographical spread because I find this a little bit interesting. The little red sun down at the bottom is Vancouver, and Canada being what it is, we all cover quite vast geographical areas, and I think the location of Vancouver is in some ways very lovely and in some ways kind of unfortunate. And we also cover the Yukon as well. Now, the distribution of our patients does in many ways follow the geographic distribution of the population. So a lot of our children come from Fraser Health and Vancouver Coastal Health, which are kind of clustered in the most southwest corner of the province. So that makes up a really significant chunk of our population. The big purple area is Interior Health, covering areas like Kelowna, Kamloops, that type of region. Northern Health, and then is in the yellow. The blue is Vancouver Island Health. And one of the reasons that we don't see that as many of those patients is because they have a very active pediatric facility in Victoria, including a very active NICU and PICU. So those children tend to receive the large amounts of their care in Victoria as opposed to in Vancouver. And then the final little tiny purple is the couple kids that we follow from the Yukon Territory. So this is kind of what we see in terms of the spread of patients. The other reason that we've ended up with this spread is because when we rolled out our program, initially we started accepting referrals only from the inpatient services. Again, we were trying to make sure not to overextend ourselves, and I'll touch on that a bit more in a minute. And also, that was sort of the institutional priority at the time, was for us to help with service to the inpatients and to help with discharge planning. But I guess as word of mouth has kind of gotten out about our program, we've been getting more and more referrals from more isolated areas. Because of this kind of large geographic spread of the patients, I think it's become very clear that we won't have the same role in every case. And I actually modified this from a conversation that I had with Natalie about how they do things in Ottawa. So we thought it would be useful to define tiers of service for our patients, depending both on geographic factors, but many other factors as well, to make sure that we didn't have duplication and that we were providing beneficial service. The first tier would be our kids who are the highest need kids. These are children who spend a lot of time at the tertiary care setting, have these long hospital admissions. For these patients, we're serving really as a primary care or a primary service. We do admit patients under an admitting service at this point in time. So these types of children could be under our admitting service. We also would see them, we would pretty much exclusively be involved in the transition to an outpatient. These are obviously children who live in the Lower Mainland. And we provide them with both routine and acute appointments. Some of these children never came to the hospital with a primary care provider. Sometimes they're new to Canada or have sort of a new event that changes their level of complexity, and suddenly they need a higher level of care. But regardless, they're sort of children that we have very intensive involvement with. I should have backtracked a little bit and said that in our outpatient clinic, we have capacity for both routine and acute appointments, and we have both admitting and consulting services in the hospital as well. The second tier of patients, the middle ground, is always, I think, one of the hardest to define. In these tiers, there are children who would have high degrees of complexity, but also have strong relationships with a primary care provider in the community, which we, in all cases, want to foster and support. So for these patients, we could provide routine appointments, and with or without acute appointments, with or without admitting them when they come into hospital. So one of, I think, the biggest challenges that we've had developing this program is just negotiating that relationship with community physicians. Pediatricians in Vancouver do not do primary care, so they often do not have capacity to see things like acute appointments, or I shouldn't say Vancouver, I'm sorry, British Columbia. So that puts us sometimes in a bit of a difficult spot, because we end up seeing them for routine appointments, and then because their primary care provider can't see, we end up seeing them for acute appointments as well, and then it can be very difficult to negotiate those two relationships. I wonder if other people have had kind of a similar experience. And then the other kind of more clear group is the third tier, which are children who have certain degrees of complexity but don't tend to be in hospital all that much. And with those patients, we tend to see them routinely about every 6 to 12 months for two purposes. One is to go over some anticipatory guidance points, which I will get to in an upcoming slide. And the second one is for us to be able to keep tabs on them, so that if they do end up coming into hospital, there's a service in the hospital who knows a little bit about them and can help with some of the management and some of the even some of the relationship with the family and some of the trust issues that have come up. So this is our team at the moment. Historically, I guess, Alyssa Collingridge is the nurse practitioner who started the program 8 years ago. She's now a .5, and we have another nurse practitioner who's a .1. We have 1.2 pediatricians, myself and Elizabeth Grant, and we share the role. So we have full-time physician coverage, which has come in very handy for things like the inpatient work especially. Definitely our ratio of nursing providers to physician providers is a little bit skewed, in my opinion, just based on some of the work and expertise that's needed in these areas. So we are working at present to try to balance that out and try to create more of a robust team. Possibly some of our most important activities, which always gets relegated to the sides of our desk, is the research, the quality improvement, and the educational endeavors that we do. This summer, we're embarking on our first kind of round of program evaluation internally. So it would have been about 1.5 years, but we want to at least capture 18 months worth of data. We're going to do basically a descriptive analysis about what patients have come to us. we're going to look at the hospital and community healthcare utilization, both before they came into our program and after they came into our program. And finally, we're hoping to do surveys for both parents and healthcare providers regarding their satisfaction with our services and what they see as additional services that would be beneficial for them. One of our biggest activities over just the past couple of months is developing an anticipatory guidance protocol. So when we're seeing these children for their routine follow-ups, we wanted a bit of standardization for what ground we wanted to cover and what we thought was important to touch on. Now, of course, a lot of that is patient-specific, but it's actually surprising how many points we came up with that really crossed most of our children who had medical complexity, and certainly the cerebral palsy population, but also just the other children who have complex needs. So we've been spending a fair bit of time working on that. We have another upcoming study that we're also working on, and this is a bit of a pitch in case anyone else is interested in looking at this as well. We've had a couple of case studies of different types of upper airway drainage positioning with prevention of aspiration and need for suctioning in our severely neurologically impaired population. So again, I could give more detail on that if needed. And finally, we never really, because we've only been on operation for a short time and only very recently acquired or hired Dr. Grant, we never really had a residency rotation set up initially. So we started having residents approaching us asking for rotations and asking for different types of educational sessions. So we are starting to build that part of our program as well. About half of next year and half of this year, we've had elective residents rotating with us, mostly R3s or R4s. And in terms of our future directions, I guess this slide also kind of outlines where we've clearly seen some of our challenges. I think evaluation of these types of programs is very challenging, and I don't know how many people were at the PAS Complex Care Special Interest Group session, and A.L. Cohen actually said something that I thought, well, a little bit disappointing, but very, very true, was that from a cost efficiency point of view and from a utilization point of view, we might never be able to have the outcomes that we'd like to see in this population just because they are so high needs. So finding a way, I guess, to prove the worth of our services in children who have such high utilization rates, I found quite difficult. So we'll see how we go by the end of the summer. The second thing is a question of integration. So in my first slide where I showed the different groups that are looking after the medically complex population, you know, I think there's a couple of ways to go about building our program, and one would be to build it as it currently is and capturing the patients who've fallen through the cracks. But the other one would there be value and interest in integrating with some of the other clinics? We've talked about integrating with Home Trick Invent, Complex Nutrition, or some of the other clinics, and creating more of a global complex care service that would encompass a number of different clinics and a number of different areas of expertise. And finally, the other thing that I guess has been somewhat challenging is to create some more formal partnerships, both with community and with other people who serve this population. I'm not sure how it's structured in other areas, but our home care services, equipment needs, all of those sorts of home-based programs are run through our Ministry of Children and Family Development instead of our Ministry of Health. So there are a few barriers, although the interest in collaborating is so high that I see this as being hopefully a fairly short-term problem. So I kind of blasted through that. My apologies, and please, I'm happy to take any questions either now or over email or phone at a later time.
Great. Thanks, Tammy, for that terrific presentation. Does anyone have any questions for Tammy at this point?
Hi, Tammy. It's Anna Cooper from Bayshore. I don't know if you said anything about it. I don't recall hearing anything, but do you have within your team any direct connection or outreach with community, with I guess specifically with the children in the community? And I guess there's my question. Do you have any connection with them other than when they come in and see you?
So we do. I guess especially for our Tier 1 patients, the patients that we're really serving as the primary care provider for those patients. I guess we have a number of things. The other area of our program we're trying to beef up is our kind of remote services. So we do home visits We have a lot of linkages with the nursing support services and Bayshore organizations here who provide the bulk of our home care organizations, and that takes place through joint home visits, joint appointments, teleconferencing, sorts of things. We kind of communicate with them on I would say, a day-to-day basis for a lot of kids.
Yep.
And the other thing that we'd like to really implement is to have some ability to do kind of over the phone or via Skype assessments of the patient in their home. Psychiatry service here is doing a fair bit of that at present, and as soon as we get a little bit of extra time and energy, it would be a great thing to be able to focus on, because anything that would not force parents to bring their children into the hospital, I think would be a very positive thing. Does that answer your question, Anna?
It does. I wouldn't mind speaking with you further about it, actually, since you brought up the Bayshore connection there. I think there's some really good opportunities that we could be looking at.
Excellent. No, I'd be really happy to discuss further.
Yeah. Okay.
Okay, great. Thanks. Anyone else have a question for Tammy right now?
Yes, Tammy, it's Natalie. Thank you for the great presentation. How is your hospital supporting you through this program project?
Hi, thanks, Natalie. That's a great question. So we have, I guess, to be perfectly frank, the culture in BC is not exceptionally innovative. We haven't had a lot of potentials for funding for new programs. So what I've really been doing is looking externally. I've applied for a number of external granting agencies to put together a pilot that would be more of a nurse practitioner-based kind of case management coordination of care pilot, which is, I know, what a lot of other programs are focusing on. The other area where I think institutionally we really need to step forward is to put in a hospitalist program. I think because I think what we're doing in our program is we're trying to cover too many bases because the needs are just too diverse. So I think if we ended up putting in a hospitalist program, I think we could have potentially less of an inpatient focus, and our workload would be less inpatient, and we could focus on different activities. I think in terms of our leadership, we have a lot of support. We just have a lot of difficulty getting funding for anything new in BC. They've been cutting healthcare budget kind of consistently for quite a few years, and Christy Clark just got back in last year, so we're maybe in for a few more years of leanness.